Thanks for joining, everyone. Whenever you're ready, you can go ahead and start.
Oh yeah, yeah. Thank you all for coming out today. I just kind of want to give a talk on AI and healthcare and public health more broadly, and I'm going to sound kind of skeptical sometimes. Sorry, I gotta. I want to sound more skeptical at times, but I think that's a good perspective to have to be skeptical because I'm pretty skeptical of AI, even though issues. So here's my disclosures. I have a lot of disclosures. Specific to this call, I'll highlight two things. I'm a principal at a AI company that does AI analytics, and I'm also an investor in a company called MyOski, which provides structured clinical education using AI instead of using doctors to teach doctors. This AI teach to doctors. Okay, so I divided the talk up into several parts. I think the first part I want to talk about is like evaluating AI's medical knowledge because like you talk to certain people and they're like, damn, they can do everything. And so I'll take a step back and be like, okay, these things we read about in the news, like how good are current uh, generative AI tools and what is their application to healthcare in that sense? And so, the classic study is a buddy of mine, Carson Gall, did on MedPalm, where they, fine-tuned a LLM to provide healthcare knowledge. And when they, deployed that initially, now nearly 2.5 years ago, they found it did pretty good. They gave it, how did they test it? Well, they gave it the medical licensing exam. And they said, like, here it is, look, it can do better than PACE. And then simply continue to fine tune the model, it continued to do much, much better. And that trend has continued even until today. I think, now they don't even give it to test anymore because they're like the USMLE is not, it can get like nearly 100 right. But I'm thinking like, damn, that's impressive. Like it passes. That's pretty clever. I'm not that kind of doc. What's in the USMLE? So I look. This is a real question from the USMLE test bank. Public health questions like this, or questions like this is like a guy asks, he's having chest pain, he's running. I'm not a doctor. I look at that and I go, what could it be? And I just want to guess, and I'm going to guess C, and I'm right. I had no idea it was multiple choice, right? And so I'm like, okay, here I'm able to guess this is right. And then I'm like, okay, well, I got a 1 in 4 chance of guessing right. What about other areas? And it turns out a big portion of the USMLE is actually on public health, about 8% of the test bank. And so I don't know anyone that doesn't know the answer to this question. What is the age of routine screening for mammography? And yeah, it can pass, but everybody passes who takes the test pretty much. These are people who took, first time takers is 96%. And then people who are repeat takers, even among the 4% who failed, about 3% eventually pass the second time around. And they don't even provide repeat testing for the second test because when I inquired, I was told that the pass rate was like 100%. So we're replicating a test that's like not, really externally valid. It doesn't appear to tell me anything about like, if a doctor did good on that test, I wouldn't be impressed. And the fact that we're using benchmarks like that tells me why medical error is a major cause of death because it just doesn't seem like we're evaluating, clinical intelligence in the way we benchmark these tools, like passing the USMLE, so what? Now, there's other ways to do it. What if we could actually evaluate it for providing clinical care? And there's actually been some work on that. A group used the NEGIM test guides, these case studies, these case reports to evaluate an LLM, in this case, GPT-4. And they took examples of these. I think they took 38 examples. And they took these examples and presented them to an LLM. And an LLM actually got 22 of them right. This is also multiple choice. And compared to just guessing, they would have got about 6 right. on a random guessing. But like, okay, interesting. What do people do who visit the NEGM website actually do? And if you go obtain that data, this is what random NEGM website visitors actually do. And what percentage of NEGM website visitors are doctors? I'm on it. I'm a nut. I'm on it every uh, Wednesday, I think is when it comes out. So I'm on it, and I take those tests just like everybody else. And so, like, what percentage of people are even actual practicing physicians currently practicing in the United States? I don't know, but just random people on the internet can start to approach an LLM. And also keep in mind that this is performing this well, even though the LLM is cheating. So there was a lawsuit, and in the lawsuit that the New York Times put as it's continued to progress in the courts, it turned out they also downloaded what? PubMed articles that were open access and medical journals articles that were or were not open access, meaning we're not testing if it knows an answer can generate intelligence. We're just testing and going, it's already seen all the NEGM cases. So why is the answer not 100% instead of being right 65%? Since it's already seen the test and already seen the results. And so I take that skepticism to go like, just applying it basically will not be very effective. Like we have to think about how to fine tune it, constrain knowledge, etc. I want to talk now about how to implement it, tools, and how we can implement it actually to help. I did some work some years ago. We'll talk a little bit about that, and then we'll expand on it with the more recent work that's yet to come out on trying to fix what everybody became a doctor for. Everybody became a doctor to write emails, right? And it turns out they didn't, but writing emails is about what they do most of the time, if they do write emails. Although, I know the data at UCSD, a lot of people don't write emails at all, but some people spend a lot of time writing emails, and it's just very frustrating. And that's reflected in the literature. Like people are stressed out. As more messages come in, they're like, okay, and now we can bill for messaging. And it's very interesting, like the intervention of billing for messaging, the evaluation of it that was published in JAMA was not on did it improve patient care, but did it make doctors happier because they had to write less emails because billing scared people away from writing. The number of in-basket messages actually reduced. But I read this and I go, well, what about the patients? They need help. Like, what are we doing for them? And so we did a study and wanted to see if these AI tools could help respond to messages. And in our study, we did a few things. The first thing we did is we used real messages, real physician answers as a benchmark, and we took on that patient's perspective. What was the quality of the response in terms of like not the patient itself judging it, but physicians judging it, a panel. What was the quality of the response? Was it very poor, poor, acceptable, good, very good in terms of like the substance of the message. And it's not just what you say, it's also how you say it. And so we judged the empathy of the responses. How empathetic was it in terms of the views of the person evaluating it? Now, here's an example of a message that we actually studied. I can show because these are public messages. Uh, we did a little trick and used the public database. Person said I got sick 3 or 4 weeks ago. I got a cough. It wasn't like there before. And, here's where they live. They use drugs occasionally through smoking. They thought they were sick and they just can't get rid of the cough. I'll summarize what's going on here. Like they can't get it. Like they just keep on coughing all the time. And they want to know, should they be worried? Hasn't happened to them before. And they think they have a really serious health condition. They have fucked up lungs. They want to know, like, do they really have that problem? And they tell you, like, hey, I've been trying these things like drinking water and, but I just feel sick and nothing seems to work. And so they write this message. Now, here's a response that they got. Like, it's common to have a residual cough for weeks after being sick, especially postnasal drip. Try some pseudoephedrine, right? And then if it's worse at night, you might have asthma and get an inhaler. Now, here's a response where it's like, okay, good to pay attention. And it suggests, though, a series of things to do, like drinking plenty of fluids, using a humidifier, avoiding irritants like tobacco smoke, perfumes, etc., and then trying over the counter medications like cough suppressants or expectorants to relieve the cough, and then talking about good hygiene and about if it continues to. But don't be worried. Here it is. Now, here's the two responses, right? And it's obvious now. At the time, it was less obvious, like who authored which, but it's pretty clear what happens here. Is like the LLM, schema theory says that when you ask me a question, I have a file cabinet in my mind and I sample over it. And I'm biased to sample whatever's most recent, whatever's easiest to retrieve, etc. So you ask me a question, I'll just say, oh, it was recent or whatever is easiest I recall first. LLMs don't have to do that. They can provide all the considerations. The doctor and ChatGPT in this case didn't have differences in information. It's the doctor narrowed in on one recommendation, and GPT provided the four recommendations, and that was reflected in our scores. We gave it a 4 in quality out of 5 average score, a 3 in empathy out of 5, and then the doctor got an average of 3.67 and 2.67 in terms of quality and empathy across multiple evaluators. I'll show you another example. Someone saying they had their Holter monitor results, and it says they have rare supraventricular ectopic activity, and they want to know, what does this mean? Is it normal? I want to figure it out. Here's one response that they got, and here's another response that they got. And you can see one is taking the time to actually go through all of the issues. And so, yeah, our evaluators preferred the longer one and gave it a perfect score for quality and gave it a 4 out of 5 for empathy. And again, the doctor's response was not wrong. It's completely normal. But it didn't provide anything that would prevent the patient from going out and seeking unnecessary care, scheduling an unneeded appointment, being unnecessarily worried, etc. And when we did this across hundreds of patient messages, 79% of our physicians preferred the GPT response to a physician authored response. And when you compare, because we're using an ensemble approach, we're having multiple people annotate each code, you can take an average, it becomes continuous. You can see the distribution of evaluations. Like GPT was, I think it was 4 times more likely to give a response that was judged as a minimally good or very good. And you're 7 times more likely to get a response that was judged as empathic or very empathic from GPT versus a physician. Now, people read this, and we wrote a really long appendix. I try to make everything I do public. I believe in open science. I share the code and share the data and everything on Dataverse. And nobody really read the appendix or went to Dataverse to get it, because people are like, yeah, of course, John, the one was longer. We selected out the subset of responses where the GPT and the physician wrote similar length response, and the findings still hold. Regardless of if the response is the same length, the GPT is preferred response both for quality and also for style and empathy. Now, this was a widely popular study. It was on the cover of the Wall Street Journal and Sydney Morning Herald and The Guardian. And everybody's like, GPT is going to take over. But the reality of it is I was much more circumspect about what we did. And that is, we provided only a early analysis of just someone's opinion. I know it's a doctor's opinion, but the doctor said, I think this is better. I think this is more empathic. Like, what does that even mean? Like, is that enough to do the work? And so one of the things we argued for is we need to develop benchmark measures for how to evaluate systems that provide healthcare, particularly when it comes to systems that are communicating directly with patients. And we've been doing that work. So we wrote a paper in JAMA Internal Medicine where we created a framework for evaluating the provision of care remotely, and what we call create trust, where it stands for, is the response correct, referenced, does it cite material, original material, and provide those citations? Is it empathic? Like I talked about before, a judgment of that. Is it authentic? does it sound like it was written by a person? Is it thorough? So like, sometimes these people will write questions and there's like 14 messages, like 14 questions, and did it answer all of them? Did it answer some? How engaging is it? Like, does it keep the patient interested? Is it tailored to the patient, or is it just providing generic? Is it respectful? It doesn't like, use language it shouldn't use. We all remember the classic case of the Microsoft chatbot, the original, where it started calling everybody a Nazi. Does it do like things, not to that degree, but is it respectful? Is it understandable? Like, how would you judge like how understandable is it safe? Like, is this message, what's the danger of someone acting this message, and is it timely? We've actually been using this benchmark here at UCSD on real messages within our healthcare system. I can't show you those messages, but I can show you some of the results that will be out later this year in I think JAMA. Here you can see we compared. I'm on a sample of data. I'll tell you what we compared. So we picked out oncology patients because we want to pick out in a scenario where we feel like the patient we're getting the best messages possible. It's a patient that's chronically ill, is engaging with healthcare a lot, and therefore relying on things like messages a lot. And we feel like the doctors there would be providing more responses versus like a GP would be less likely in an academic medical system. And we use various LLMs instead of just one. So here we're talking about GPT and then Mixtral, a public source one. And what you can see is that like healthcare providers in this setting were actually more correct than either LLM, but not significantly so. But you can then see like when it comes to Taylor G down on the fourth column on the left, you can see like physicians were way more tailored, meaning like they were providing advice specific to the patient. Makes sense than what the LLM could, because we only gave the LLM a summary of the chart. We didn't give it the full chart. And then it was way more authentic. But then there's other cases where you can see from this data, like what's actually happening is like, well, sometimes the LLMs do better. It's more referenced, like it will cite material to like assuage the concern of the person sending the message, top right column. It's also more thorough, meaning it answers all of the questions that are asked, and then also more empathic. Meaning it gives a response. But I want to also notice something too here too. We don't talk about this. We talk about mean effects. Look at the variance. The variance is statistically significantly smaller for every concept except for respectful for the LM versus physician. So, like, even though the average may be true, some physicians are overperforming and some physicians are seriously underperforming. But the LM provides a mean response that's more the modal experience. So even in cases where they're equal, it could be preferred. One thing I want to ask is like, well, when you're developing a measure like this, it's like, it's great. Okay, now John, you tell me you have to use, all 10 of these. Like, don't they measure the same thing? And it turns out, yes, they're really correlated with each other. A message that does well, on safety also typically does well on being thorough and doing well on tailored and being respectful and being etc. But one thing doesn't really correlate very much, and that's being referenced. And being referenced, providing citations or providing resources for the person to go evaluate doesn't really predict how good the quality of the message is. And that is kind of surprising because like we're taught in science to always show your work. In this case, showing the work is like not related to the other concepts very much. Slightly, but not much. Everything's positive related, but higher in one, higher in the other, but only slightly. But we take these and we summarize these into a benchmark score. And we go, here's the benchmark, the Create Trust score. And we can see like, again, now the distributions are very similar across all of the metrics. Healthcare providers typically will have some outliers that better perform, but LLMs they're like a safety net. The bad perform, they do their worst performance is way better than the worst performing clinician. And so now we can figure out not how to think about replacing your doctor with a tool and saying it's great. We can now think about how to benchmark the data, how to have more holistic understanding of the data, and being critical of the data and actually interrogating the data beyond just like, is it better or worse? Consider things like variance, underperformance, overperformance, et cetera. And so we're open sourcing this work. And so it could be applied to any data on clinical interactions. You can even use the Create Trust Score to like evaluate videos of physician patient interactions. And we're hopeful that it'll be a widely popular benchmark. Current benchmarks, I should say, Health Bench out of OpenAI, again, only judges if it's right or wrong, which, you know, not very meaningful. What's one of the ways these tools have been implemented so far is through clinical decision support. Right? That's all you ever hear about. Like you pick up, you know, in these hospital review publications, like, hey, we're using clinical decision support. We want to make every doctor better by giving them a tool. And it's insanely popular, but I, I don't know what a clinical decision support does because oftentimes it takes and tries to replace what the doctor is actually good at: critical thinking, summarizing information, and making a diagnosis. Why do we need to replace the doctor? What if there was another way to use AI tools to support clinicians rather than trying to replace them? We'll talk in detail a little later about an example of that. So we coined the term clinical action support. So traditionally, like we'll use the example of messaging, so I've been talking about. So the traditional model is patient writes, doctor responds, right? The clinical decision support says be a patient writes and AI drafts, the doctor responds. That's currently how it's being implemented. The clinical action support would be patient writes, doc drafts, AI enhances and responds. So we're not using AI to be an intermediary. And this is true for messaging in all areas. We're not trying to be an intermediary between the patient and the physician. Instead, we want to take everything the physician is doing now and not replace it or intervene, but enhance that. Hence, it's not a clinical decision support. We're not impacting the decision the clinician made. We're carrying out the actions that the clinician's already made. And I think this happens in practice all the time. I remember back when I was Hopkins, I'm not that kind of doctor. But I used to go around and do rounding because Dan Ford would be like, you need to go see, you should be a real doc. And I'm like, no, I didn't become a real doc. So, but I went around, did GI and a couple other things and walked around. It was embarrassing. They had to be like, John needs special permission to be here. And I remember seeing like over and over again is how does it work? Well, at the top, decisions are carried out as abstractions. We need to do X. No instructions are provided. And then, a resident, an intern, a nurse practitioner, a nurse will carry out those instructions, carry out that action without additional instructions, and do it on behalf of the abstract decision maker. That's what clinical action support actually does. It doesn't reinvent the way we think about making decisions in healthcare. Instead, it accepts that current model and goes, how do we use that current model in the case of healthcare? Now, we actually did it with messaging, and we did it using this workflow. Traditional, patient writes, AI drafts, doc responds. Okay, patient writes, doc drafts, AI responds. Now, these are the ranking of these three approaches. So on the left is better, right? That means you're more likely to be ranked the best response for a given message because these are nested within, three observations for each. And so we rank them. We go, which is your first preference, second, third? Blows it out of the water. Like you actually get, remember I showed you all that? I said LLMs they do about as good on some things. They do better on certain other things. But on average, they're doing about the same, but less variance. Now we can actually improve the quality of messaging by, instead of replacing the doctor, taking what that doctor wrote and adding more context to it, prettying it up, changing the way it's presented to the patient to make sure it's understandable, taking in all those attributes of create trust, which we do in this prompt, and then carrying that on. And so it's really cool. Like it's a clinical decision support to me is dead, and we're replacing it with clinical action support. If anybody's talking about clinical decision support, it fundamentally has not been demonstrated to be the ideal method. And we are creating evidence to demonstrate that clinical action support not only is a more theoretical grounded method, meets how healthcare is actually delivered, but it actually produces better results, substantially better results. So why is it I just told you we have those clinical decision support and we don't know if it works or if it, provides any benefit, and that's because of the way we regulate AI for healthcare. Um, Current AI methods are all a black box. It's kind of like hope and pray. Read the press release, use it, and see what happens. And this hasn't been going on for the last 2 years. It's been going on for a long, long time, particularly around things like sepsis prediction. Uh, so, how do we implement sepsis prediction? We use various features from the patient, and we create a alert system to alert the provider that a sepsis diagnosis might be warranted. Theoretically, that's what happened. What's actually happening, we'll talk in more detail a little later. But it turns out these things are never evaluated. They're not required to be evaluated, these clinical decision support systems like this. But when they don't do so hot. So this was the first external evaluation of Epic's sepsis prediction system. And in this study, they found among 2,552 hospitalized patients that developed sepsis, only 7% who did not already receive early treatment were identified by the clinical decision support system. Only 7%. So 93% missing, 7% captured. But then what about false positives? And or and then 6% of patients who developed sepsis were never identified. So it's not identifying, it's not actually like you read this, and you're like, is it telling me anything?
I'm sorry.
But actually, the way this is presented in the news is like it works. Groundbreaking new research associates decreased mortality with the use of clinically approved AI platform for sepsis detection. This happens over and over and over again. And so what I want to do now is do a little bit of a lesson in critical appraisal about how to read these studies so that you can also evaluate them and decide if the headline is true or not without waiting for someone else to do the first external evaluation, because external evaluations are not required. So this is a study that's actually the basis of that claim I just showed you on Bayesian health. The study published in Nature Medicine. And you read the study, you go like, okay, they're saying it saves lives. What do they mean? Well, okay, they tell you they have a very beautiful flow chart. And they tell you like, hey, we have patients. Some are going to get the system, some are not. We want to, and then compare the two and be like, okay, one group got the AI tool and one group didn't. Okay, and we're going to evaluate if it saves lives, this clinical decision support system for sepsis. And they give you a result. And they go, look, among people who got treated, the mortality rate in the hospital was 14% who got access to the sepsis. Their doctor had access to the AI sepsis prediction tool. And those who didn't, 19% mortality. And so about a 33% relative increase, right? But is that what they actually did? I read appendices. You go to the appendices, you read about the study. Here's what they actually did, not what they showed you in figure one. They compared outcome between two patient arms, patients who had their alert evaluated and confirmed by a provider within 3 hours of the alert, and patients who did not. Whoa. So the whole group that didn't have access tool, they're not included. Instead, everybody has the tool. And people who's had a doctor who used the tool clicked, and what this means is like evaluate it. There's a series of drop-down menus and check boxes. So the doctor sat there on the EHR and clicked around and went, yes, check. Yep, this is right. And they did that within 3 hours of the alert first being created. They're in the got it group. And patients whose doctor had the tool, but the doctor didn't do that, are in the did not got it group. What's the problem with that? It's confounding my indication. If I'm playing on the EHR, it's because I'm not doing CPR on the patient. Therefore, the patient's going to be doing better. So, clearly it's just a bullshit study. It's telling us to believe something that just fundamentally isn't true. And you don't get that unless you do what? Read the appendix and think about the inclusion exclusion criteria and think about how these things are actually operationalized, not as a simple parallel pre post design. Parallel pre post, and we don't do this naturally because because tools are typically evaluated. We trust the FDA, we trust others to do it, but these tools are not. Now, maybe you might be thinking that's changing, John, but it's not. The White House executive order on AI and regulating AI actually says, well, actually does not say the phrase patient outcomes or outcomes in the entire order, not once. Instead, we live in the Wild West where you can make any claim like they do at Bayesian. You can publish a study that allows you to do research as marketing, hoping nobody reads the appendix, and nobody will. And you can go out there and tell. And so if you're like a healthcare administrator, you're a physician, like what sepsis prediction tool should you be using? Which one works? You don't know, and you cannot know. And so your default behavior should be to assume that they don't work. And then your second behavior should be to advocate for the inclusion of patient outcomes in the evaluation of AI in healthcare, which is something we wrote about in JAMA, where we called for a regulatory structure where AI is evaluated just like we do with biologics or just like we do with drugs. And we know if it works or doesn't work. I mean, if I'm a patient, I don't know if I want an AI sepsis prediction tool used on me. That's not a good position to be in, particularly when that style of AI has been with us now for going on 15 years. And yet we still can't answer that fundamental question. How are we going to know how to use anything? So we have to be skeptical and probably say, ugh, we can't unless we advocate for better evidence. Now, I spent a lot of time today telling you about how I think a lot of stuff is overblown. Like the most popular form of AI, sepsis detection, is all bull, and there's no rigorous external evaluation of it, et cetera. And I've told you that the whole system of clinical decision support is wrong, that we need to move to clinical action support and not try to replace the doctor, and that you shouldn't be impressed that an LLM can pass the USMLE. But let's not be a negative Nancy. What can we do to actually make a difference? And I actually have been thinking about this. I did an interview on Fox News. They called me in. I turned my camera over here to get my nice backdrop. And you know how it is today with COVID, you just do it in your house. So I'm doing the interview and I didn't read anything they asked me to read. And they're asking about some study. And they're like, John, isn't this great? AI saves lives. And, I smile and go, yeah, yeah, it's great. Great, great. But when I hang up, I'm like, that's bull. AI ain't saved nobody. But that's actually something to be sad about. We have a revolutionizing technology and it's not going to help people. How do we make it actually save lives? And so I sat there and I thought about it and I'm like, okay, I'm going to go put my public health hat on and think about determinants of health, think about the most distal determinants of health. And I'm going to be like, okay, what could AI do for there? And I'm like, I can't come up with anything good. I'm like, okay, what about for in the healthcare setting? Okay, I can't come up with anything good. Sepsis detection, all this stuff I don't buy. Like, what could we do here? What could be good here? What could actually work? And then it dawned on me, if somebody asked me to save a life in the most proximal way, I couldn't. I don't know how to do CPR. And if you look at this literature, most people don't either. That when people have out of hospital cardiac arrest, their chances of survival is about 8%. And that's because they don't get access to CPR. But when they do, we can elevate and increase their chances of survival. And so here we can see like when we actually implement CPR that we can almost double that chance of survival. We can almost quintuple that chance of survival to like almost 70%. And then we also can see like, okay, but our people know how to do it. And people will tell you they know how to do it. It's really interesting. They did a survey in this case. And this study was really clever. They did two ways. They asked people, and like 68% of people said, I know how to do CPR. And then they looked at the records, and it turns out during the study period, how many people actually got trained for CPR? Less than 3%. 68% of people feel like they know how to do CPR. 3% have actually been trained. And this isn't a trivial issue, right? Peter Provenose became famous because his first study, people forget, wasn't the checklist, right? What was his first study? His first study was your distance from the crash cart predicts your survival rate because seconds matter. And the early administration of resuscitation efforts will increase your chance of survival dramatically. And if you look at the actual data on 911 calls and how interventions do in the wild, they don't work. The average 911 call takes about 93 seconds, I think, before the operator even identifies a need for CPR. And we know from the work like by Provernost and others that in a hospital setting, by then, you're kind of just going through the motions. The chances of it working, slim. So what do? We came up with a checklist of how CPR should actually be communicated to people in the wild in the case of out of a hospital cardiac arrest. And so we're going to checklist trying to mirror the way we think of TCPR, so telephone CPR. So like that's what they call it. Like how do you provide, how to give advice on how to do CPR over telephone, and 911 operators use a TCPR script. And so we created a checklist of things to do. Here, this checklist in red are things that are minimally viable CPR. The things in black are things that would be nice to have, gold standard CPR. And you see, like making sure the patient, is checking their breathing, making sure that they need it, instruct them to actually do the compressions, the depth of the compression, etc. And so we developed this, and instead of picking one LLM, we picked 6 LLMs, and we fine-tuned these public LLMs to go and be CPR educators. And what could they do to actually teach people to do CPR? And what we did is we created archetypes, synthetic archetypes. We said these are cases of someone needing CPR, like a kid falling in the pool, a baby, because it all varies. There's not like one way to do CPR. It depends on pediatric, not pediatric. If drowning versus not, etc. And so we took these vignettes and we wrote them, and it turned out that LMs did not do a very good job of it initially, but we could actually get them all to do a pretty adequate job, where 90% of that checklist I just showed you could be achieved. But that doesn't mean like we're using a synthetic example, like we're picking out, making up scenarios and seeing if an LLM fine-tuned can respond to CPR, right? What we're fine-tuning here means like we give it instructions to rag over, we give it prompts to instruct on how to use those documents, etc. But what's a better benchmark? The real world. It turns out 911 calls in a lot of states are public. And so this is a script of a 911 call that we have, where the operator is answering, and the caller is like, my husband had a heart attack. Okay, what's your name, Brooke? Okay, we're going to start CPR. I'm going to tell you how to do it just immediately. Think of what happens. They're not assessing the need for CPR. Okay, see an error there already. Like, lay him flat on his back. Okay, expose his chest. Okay, they're not confirming that anything's happening, right? Like in our checklist. And when we compare our best performing fine-tuned model to actual 911 operators, we blow them out of the water. Where we build a multimodal CPR coach. And so now we can hit 90% of the checklist by taking real 911 calls and deleting what the operator says and replacing it with an AI. And it means that we can make CPR disruptive. You don't even need to call 911. The llama model we fine-tuned around was not the 420 billion parameter or 70 million parameter model. It was, I think, the 3.1 million. It was the one that can run on a tablet now. It'll run on a phone probably next year. The phone model didn't work very well. But like we're trying to democratize access to this. So we're trying to, release this fine tuning, and by doing it, all LLMs make CPR available to everyone. And so in the future, you could ask Cortana or Siri or et cetera, and you would get a real-time live CPR coach telling you how to actually save a life. And so we're really excited about this. So I know I was negative on AI a lot, but I think this is one area to be positive on. Okay, thank you very much. How do I stop sharing my screen?